something that I really thought about, and I ended my speech with this quote, and I've kind of lived by this quote my whole life now, which is, winning isn't everything, it's the only thing, especially when the game is your life. And that's something that I've always thought about. Should be getting it tattooed somewhere on me at some point, but I haven't gone that far. But that's just from day one. That's something how I think and believe about. So I'd just like to thank you all. Hopefully it's you guys got something out of this. I enjoyed the time. Thank you very much for having me. And I guess it's time now to pass over to Dr. Koehne. And thank you very much for everything.
Brandon, thank you very much for this inspirational story. And you not only inspire others to help, but you also inspire physicians like me to continue what we are doing. And it's no surprise that you still have these vivid memories from 1992 and basically remember every single day that you had to go through the mouth pain, the infectious risks that you had to go through, the lumbar injections and so on. I think that will stick with you, but you concluded certainly and moved on with your life. But I get inspired by patients like you. I hear stories like this. Also ask the question often, do we really have to do this to our patients and continue and expose them to high-dose chemotherapy as you have been? And the answer is most of the time, but it's changing. I was asked to speak a little bit about changes maybe from 1992, and as Dr. Zinner introduced myself as the Deputy Director of Miami Cancer Institute, the Chief of Marrow Transplantation, Hematologic Malignancy, I've been a leader and also focused on immunotherapies for many, many years, and started already in 1992 when I came to New York to join shortly thereafter Memorial Sloan Kettering Cancer Center before I came to Miami Cancer Institute. My focus has been to see whether or not we can do better than chemotherapy with a desire to change and integrate or even replace these treatments with immunotherapies. And so I was asked to talk about a little bit of focus on pediatric cancers, although I'm not treating children necessarily, but 14-year-old are not necessarily children anymore with a non-Hodgkin lymphoma like you had, and onwards from there, with maybe a little bit of a positive note on unrelated treatments, where we try nowadays to move from chemotherapies to immunotherapies as a combination or as a single entity. So I'm going to share my screen, and can you see my slides now?
No, Dr. Koehne.
Not yet, okay.
Not yet. There they are.
Okay, all right, thank you. So here's what I thought to do and talk to you a little bit about chemotherapy or immunotherapy. That is the question, or is that a question? Along the story that we just heard from Brandon, these are sorry about that. Here we go. These are the impressions and pictures that we are used to seeing in children and in adults. Here we have a very impressive, I would say, picture of a young boy that got powerful chemotherapy for the treatment of leukemia, and the sister in the background tries to comfort the brother. So that's nothing we are not used to be seeing. We also know how we try, and patients try to help themselves to try to reduce some of the most feared side effects, such as hair loss. And this woman undergoing chemotherapy for breast cancer has an ice cap on the head to try to prevent the hair loss. Well, whether or not that's worked or not has never been really totally proven, but we try, of course, with every individual to reduce as much as we can. But just as I thought about reporting on advances in the treatment of cancers and some of the hematologic malignancies, such as non-Hodgkin lymphoma that Brandon also experienced, and Hodgkin's disease, clearly show some advances, and I will get back to that in a moment. Azra Raza is a colleague of mine that I got to meet a long time ago in Chicago in 1996 or 7 for the first time. She is a hematologist oncologist, and her husband is, at this time, Harvey Preisler, was the chief of the hematologic malignancy at Rush University in Chicago. And she came out with an essay in the Wall Street Journal just recently saying cancer is still beating us, we need a new start, and asked the question, would it be better not to try to kill the last cell rather than to focus and fight the first cell, or the other way around? So I think that's a reasonable thought. Whether or not that's possible is the other question. But the reason why she did that essay is because here she is in 1996 with her husband, Harvey, who also, like Brandon, experienced as the chief of hematologic malignancy and a specialist in non-Hodgkin lymphoma to get exactly that. And that is a non-Hodgkin lymphoma, the diagnosis for non-Hodgkin lymphoma. And he had to be treated with systemic chemotherapy, and he did not survive the side effects from the systemic chemotherapy, which prompted Azra later on, who's now at Columbia in New York, to write this essay. Still vivid memories 30 years later or so about her husband and the story she had to go through. So it is mind and life changing, and therefore no surprise that Brandon is still thinking about this on a daily basis. Now, what can we do though? This is just to impress everybody about my own work with one slide. Here is the immune system that I'm talking about, and you may not have to understand all of this, but this I wanted to show you is a PET scan, and everything you see here black, with few exceptions like the heart and so on, is not good. It's a non-Hodgkin lymphoma. This is what we call an EBV-driven non-Hodgkin lymphoma that happens and develops in patients after an allogeneic stem cell transplantation that they do get for other diseases such as leukemia. But this is a very aggressive non-Hodgkin lymphoma. It is EBV, Epstein-Barr virus driven, and has a very limited chance to survive. And this particular patient that I remember very well was treated with the standard of care, which is this monoclonal antibody called rituximab. But you can see the tumor load just did not go away, and the PET scan here, despite of treatment, is full of non-Hodgkin lymphoma. There was one of the first where we at Sloan Kettering Cancer Center at the time utilized the immune system of the donor to collect immune cells called T lymphocytes from that donor, get them into the laboratory, and grow them in culture to make them specific to recognize the lymphoma cells. And this was one of the first. In fact, I think it was the first treated with this approach. We infused these cells after 4 to 6 weeks in the laboratory, manipulating them into the patient where he was almost ready to get intubated because of the nodes and the swelling in the neck. And then the cells got in, and you can see over time here, the non-Hodgkin lymphoma just disappeared. And this was a first, evidence that these immune cells can really treat these very complicated and aggressive lymphomas. And we treated lots of them in the meantime, and most of them, at least I should say, successfully. Now, today, we have another approach to treat non-Hodgkin lymphoma with immune cells, and those cells are called CAR T cells, or chimeric antigen receptor cells, which are also manipulated in the laboratory to recognize the lymphoma cells specifically. So here, what I showed you in the first slide, and here in this slide, we are treating non-Hodgkin lymphoma with immune cells in the absence of chemotherapy. This approach is a little bit complicated, but very effective. in the absence of chemotherapy. What we do here is we'll collect blood from the patient first, get it into the laboratory, and then we have to stimulate the cells to be able to do some gene transfer. The gene transfer means that we integrate into the cells in the T cells a new molecule that recognizes specifically the molecule expressed on the tumor cell to kill the tumor cell. So this CD19 molecule can, after transduction, be expanded in larger amounts of T cells, and they will be reinfused back into the same patient, and has a very high chance to get these patients in a complete remission without the chemotherapy. Now, it's still not an easy home run or a polo ride, if you want, by just giving the cells and then get the patient into remission. There are lots of side effects that are a little bit beyond my time to allow to speak to you, and they can all be managed, but it's a very potent approach to non-Hodgkin lymphoma. So this opens then the door to think about, do we need chemotherapy, or are there other ones, other treatment approaches down the road that will potentially replace the chemotherapeutic approaches? And therefore, I just wanted to draw your attention to another disease that has a not so good outcome if not treated appropriately, acute myeloid leukemia. So along the same line, so here, like non-Hodgkin lymphoma, since 1973, for almost 40 years, we had two drugs, idarubicin and another one that called one was given for 7 days, the other one for 3 days, called 7+3, and that was the only approach to treat these patients with leukemia. Then in 1977, we started to think about bone marrow transplants to cure the disease, and has been a long ride that we can do this in a better approach now, integrate chemotherapy with bone marrow transplant. Nowadays, we know for a fact also that bone marrow transplant, not as 1977, given high-dose chemotherapy to kill the last cell, that was the intent. And everybody who was supposed to get a bone marrow transplant at this time and even until later was informed, we need to do this because we have to give you high-dose chemotherapy. And with the high-dose chemotherapy, we hope to kill the last cell, but we also kill basically the bone marrow function and the immune system, and therefore we have to give you back the stem cells. So that turned out to be not really the rationale and the effect of transplant, because this transplant is immunotherapy. Today we know that the donor's immune system that gets transferred with the stem cells is the cure of these diseases. It's not the chemotherapy, because the last cell is not found by chemotherapy. The last cell is found by the donor's immune system. And therefore patients with a hidden tumor somewhere or a few cells get cured because they can find those cells and eliminate them. Now, the reason why I bring this one up, then in 2013 and now onwards, we all of a sudden developed a whole series of new drugs that are very complicated to pronounce, and you don't have to repeat this over dinner tonight. But all I want to say is that I want to point out that all of these drugs here listed are not chemotherapeutics. They're specifically targeting the cycle of the tumor cells, and most of them are immunotherapeutics. So they are now being investigated in combination with the chemotherapy and in combination with themselves, more or less, to see whether or not we can reduce the amount of chemotherapy administered. It gets even more impressive if we look at the landscape of another disease called multiple myeloma. We had two drugs until 2003, then a fourth one came up, and then an old drug that was basically abandoned years ago, thalidomide, came back on the market, and you can see here that all these drugs now are available for the treatment of multiple myeloma, including vaccines, including CAR T cells and other drugs listed here. None of these drugs are chemotherapeutics. They are all specifically targeting the myeloma cell in this case, or are immunotherapeutics. So what I hope to show with with these slides in the short time period, then there's a significant shift right now from chemotherapy away to more immunotherapy, or more specifically targeting the tumor cells. And that is the message I would like to leave you behind with for today. Thank you for inviting me.
Hi, my name is Matt Hall, and I am a radiation oncologist at Miami Cancer Institute. Thank you all so much for being here today. First, let me please thank Brandon for telling us his story, his battle that started at the age of 14 and has extended through to the present to overcome cancer. And I'd also like to welcome friends and colleagues here in Miami, and patients and families here locally in South Florida, but as far away as India. So a very special welcome, and it must be the middle of the night there. Today, I'm talking about cutting-edge radiation therapy, but really it is a discussion not about radiation, but about the future of cancer therapy and where we hopefully shall be going from here. So 25 years ago, the survival rates for pediatric non-Hodgkin lymphoma were not so good. But in the present day, they are now better. And 5 out of 6 children like Brandon will be cured of their Hodgkin lymphoma. But what's true for non-Hodgkin lymphoma is true for many pediatric cancers, in that our patients who survive are subject to many long-term treatment side effects. It can affect our brain, it can affect our body, it can affect our heart. And all of these things across every cancer can shorten life and make that life that has been saved that much more difficult. And so we as physicians need to listen to where we are going and try to not only cure, but also heal and protect as patients like Brandon grow up and move on to so many more important things than the past that was their cancer therapy. And there are certain ways that we can do that, and one of them is incredibly important in patients who have lymphoma, and it's avoiding radiation whenever possible. We now know that some patients can be spared the side effects of our treatments when an equally effective alternative is available. But even when radiation treatment is absolutely needed, and many of our patients that see it today need it, we can use lower doses than we did before without compromising cure. We can treat smaller areas, and we can use the most advanced radiation therapy, such as proton therapy, to minimize treatment of critical organs and minimize problems in the future. This is an example that comes to us about the effect of radiation on the brain. And with the red line, normal radiation affects the brain, and that affects you every year afterward. And so it is a continuous decline for the future. But with proton radiation, scores in this population were stable and did not decline for reading and math. And those are so important for our children who are going through school and college and graduate school. This slide is a little bit busy, but I should note that this research came in part from the very hospital where Brandon was treated in Toronto, Sick Children's. And it demonstrated that many cognitive domains are spared by proton therapy, such as IQ, memory, reasoning. And it is so important as we look to the future that we put our children and our future adults who will take over for those of us working in the position to succeed. And the way that we can do that with radiation is by minimizing the low and intermediate dose radiation exposure using advanced forms of treatment. And what I would even describe as an advanced form of treatment is our best example on the left-hand side. But compared to proton radiation that we have here at MCI, and increasingly at new places around the world, we can significantly reduce radiation dose to the memory centers, to the hormone centers of the brain. And if you look at the picture on the right, the green part of the brain and the yellow part of the brain, right to the right and left of the area where the tumor is located, those are the memory centers, and those are what we are sparing with radiation whenever possible. And we can even model what is going to happen as a consequence of radiation because we do have experience and we know what happens to children and adults long after their radiation occurs. And we can predict who should travel for radiation and who will not get the benefits. And this example of the patient I just showed you demonstrated that we were able to significantly improve the chances of this young patient having preservation in their memory by simply using a better form of radiation. I want to briefly conclude that radiation is not just protective or cannot just be used to protect the heart, but it also can be used, or is not just used to protect the brain, but can also be used to protect the heart and other parts of our body. Because any dose of radiation on the heart is bad. And this is certainly seen for lymphoma based on this wonderful work from Europe. But it also is relevant to our adult cancer patients who come to us for breast cancer who have exactly the same dose response. And I show this picture because in the picture we see what the heart is supposed to look like. It's a big muscle that is responsible for pumping blood to the entire body. And in the top right corner of the heart on the picture, that's the effect of radiation, which has basically made that heart muscle not pump as well. And we can see that in this picture of what our former forms of radiation look like and what our proton radiation look like, because the target is right in front of the heart. And it has been shrunk by chemotherapy, but it is not dead, and these patients needed radiation for cure. But what we see in the bottom picture is that we are able to reduce dose to the heart, we are able to reduce dose to the lung, and we are able to reduce dose to the breast to reduce the risk not just of heart disease, but lung cancers and breast cancers that are a consequence of our treatment and can happen many, many years in the future. So I just want to briefly sum up with my thanks to Brandon for being such a wonderful role model to patients here in Miami and across the world as to what it means to overcome cancer and what it is to really serve as an example of how a difficult time in your life can really lead to changing it for so many other people. I should conclude that our job as doctors is to avoid and reduce the use of radiation whenever possible without compromising cure. But that when we need to use curative treatments, we need to work and use the best possible types to minimize the complications that come afterward. And I hope that I have briefly introduced that survivorship and preservation of function really need to be the cornerstone of where we are going with cancer care today. And that is so much a part of what proton therapy, immunotherapy, and targeted therapies that Dr. Koehne have talked about and really do represent the future of where we are headed. Thank you.
Wow. I want to thank all of our participants. Brandon, that's just an incredible story and wonderfully told. I want to make sure I did get that message that you said. Winning isn't everything. It's the only thing if it's your life. Did I get that right?
Yes, yeah. Winning, it comes from the old, I can't remember who originally said it, but, winning isn't everything, it's how you play the game. And I was like, no, we're going to change that. So winning isn't everything. It's the only thing, especially when the game is your life. That's kind of where it all came from.
We may end up with that as our takeaway today, but there have been a number of questions that have come from the audience, and I'd like to begin to ask a couple of them. Brandon, you had several questions. One of them was, you said early on when you were describing your spinal taps, your punctures there, that you could let your mind drift away into a beach. That's such an important concept of how patients deal with adversity and difficult challenges. How did you do that? What was it in you that allowed that to be so successful? What can you share with people who are going through the very, very same thing?
Well, the biggest ingredient I had for that was obviously my mother. It was all her idea. But no, because I was taking, they would